Thank you for the opportunity. I'm going to talk on a cubicle that we innovated recently. So this is a do-it-yourself template. The reason being, so when we see a patient in our OPD, in a tertiary eye care center especially, when we give a particular investigation to be done for the patient, what tends to happen is if it's a geriatric patient, they have to go to different levels. So sometimes they'll have to go to different levels to get an investigation done. So this is a level 1 and some instruments may be in a different level, in another level. So there is a lot of patient mobility inside the hospital, especially if it's a wheelchair patient. So this was a simple idea. Why not we assemble all the gadgets at a common place? So that was the apple tree thought that made us possible for this innovation. So the OPD space was actually now converted into a conveyor belt model. So conveyor belt model being first having an investigation and then the belt-like approach. So all the important gadgets that is needed for a comprehensive eclectic ophthalmic investigation were brought under 16 feet length, 16 feet breadth and 8 feet height. Total occupying area is 256 square feet. So that was the working area, and this is a video from the insides of this particular cubicle. All the eclectic setup, there is a slit lamp with an applanation tonometer, autorefractometer, lensometer, non-contact tonometer, and leading on to another slit lamp. So we had, at the time, 2 doctors can actually be in this cubicle with a fundus imaging device, an EMR with a printer attached to it if you want to give the printouts, optical biometer, manual keratometer, so to name on. So these kind of gadgets were brought under a common roof, and also for safety purpose, because at the end of the day we need to lock the sliders because we don't want any machine to get broken or something. Maintenance wise and the patient's comfort of use while placing the footrest, because for different instruments the angulations had to be given different. So this is a conveyor belt model. As you can see, the patients actually can sit in a conveyor belt model and the investigations can be done quite easily, reducing the patient's wait time. And this is the inside of the cubicle and the outsides of the cubicle respectively. So this actually was done on May, especially during the COVID period, which served a lot of use for us. So these are the things that you need: an aluminum beading, jigsaw cutting blade, an adhesive, and there you get the cubicle. So we used acrylic sheet, 8 mm thickness, aluminum beading, 2 into 2 inch and 4 into 4 inch, and 20 and 4 pieces were used respectively, and the cost of it came approximately 3 lakhs. With the labor and cutting charges, it came approximately 3.4 lakhs respectively. It's cost effective, less space consuming, easily constructible in a do-it-yourself template. And these are the workflow pictures that you can see in different stations that is needed for an eclectic comprehensive setup. We also did publish this, and we also added one more feature called the local area network, where all the data will be at the fingertip of the treating doctor inside the cubicle. So special enhancements like a voice enhancing microphone with a speaker can also be provided for enhancing doctor-patient relationship, along with visual counseling of the patient at the different stations in the conveyor belt model. So we also validate the cubicle, and since the inception we have performed 95.95% of our ophthalmic examinations with the gadgets inside the cubicle. Special investigations like IDO, visual fields, duct syringing, these were the things that was actually done outside the cubicle. So it is still holding good for us. We started this during the COVID time, but still I would say the results point out that a small workspace of 256 square feet is enough. Even during COVID, when we used this, only 29 medical and paramedical staff never tested positive within the 2 weeks of their duty inside the cubicle. And moving post-COVID era, it is a state-of-the-art cubicle which is for a comprehensive evaluation of the ophthalmic structures, which is universally applicable, and it gives hope that even a 256 square feet, a small working distance, can be useful. The limitation is it is just like, it doesn't substitute a tertiary eye care, but it could serve as a preliminary setup for the future practitioners who are going to practice this. Thank you.
Thank you so much. Dr. Swapna Nair, ma'am, can you please give your comments on this?
I wanted to know whether, how easy is it to do a suture removal or a foreign body extraction when you have, that kind of a window?
Ma'am, this started during the first phase of lockdown. At that time, we had another physical barrier for the slit lamp. At that time, we had the hand getting, we had the discomfort of not able to remove. But now we have removed the barrier that we use for the slit lamp during the COVID times. So now it is as easy as you seeing a slit lamp outside the cubicle, seeing the slit lamp inside the cubicle. It's as easy as the same.
That means you've enlarged the window through
we did enlarge the window. So after the COVID times, we made certain modifications. Before COVID, we had a separate AC outlet inside the cubicle and the outside the cubicle. Now we have not concentrated that. And before COVID, we had an opening for the leg. So with the leg, we used to open the door, and with the leg, we used to close the door. And during COVID, we also had a single rectangular sheet where the case sheets can also be transmitted through it. So now certain modifications have been done, and post-COVID era, it is like area where we have review patients who have already been ticked visual fields, OCT has to be done or fundus photo has to be done. They come in, they register. So like a conveyor belt model, we do the investigations and they'll be placed for the doctor. So that way we give the appointment accordingly, so the time can actually be saved, reducing the patient's waiting time, giving them a better approach of the investigations, ma'am. Yeah.
COVID has taught us a lot of things. And I think having that much of open space in every clinic is a little difficult
places
and
like Bombay, I
challenging.
think the entire clinic will be only 20 square. It will be outside the clinic.
Yeah.
So the idea is
Rooftop.
Rooftop.
so the
No, the
current
only
idea-
thing I wanted to ask
With a
was
cafe on the other
like,
side.
If there are some 30 patients who have coming in and everybody needed one investigation, then wouldn't the waiting time of each patient increase because they have to get into this 250 square feet and then come
Yes,
out?
sir.
Would there be a limiting step here?
Sir, during the COVID time when the OP was very less, we didn't have the problem. Now as the OP is increasing, what we did was, certain investigations are also available in the other platforms as well. So we prioritize the patients who are actually needed to have it. So those patients alone, they come into this conveyor belt model. Other patients, as routine as possible, they'll be having the routine route, sir. So we have 2 routes of operation now. So that's how it's going, sir. Yes, sir. Sir, actually in every station there is a microphone and a speaker, one for the doctor and one for the patient. So though there is a physical barrier, so only thing is like as you speak, the patient will be heard in a much amplified way. However crowded the OP is also, at every station there is a speaker and a microphone. So that's what I just depicted in. Sir, a noise per se, this is
I
quite
think
normal
we need
to
to do
what
a study
we-
to see how much less COVID cases
Yeah.
we could do
No,
because of.
He said that there were no COVID cases in his duration of
So
time when the
during
study was
the
done.
2-week
Yeah.
utility.
I'm sure you had assistants outside who would, help circulate the patients and do the.
Yeah, ma'am. Yeah, ma'am. Yeah.
So
Dr.
any
Seema,
one of
can
them
you
actually developed
blow
COVID or
this
not
in?
would be the.
So in second
presentation
wave, yes, sir.
Anyway, of course, it does not directly correlate with
Yes,
this.
sir.
So many of the healthcare professionals got COVID from outside. So great, but
Yeah,
very
very
nice.